I think Dr. Chari did a fantastic job with that introduction of newly diagnosed and in relapsed refractory. And once I get my slides up, I really don't have as much data on all of our CAR Ts and bispecifics because, as you heard, 90%, 100% response rates is something we've never seen. But basically, what I want to talk about is the concepts and sort of, why we're seeing these things and sort of where we want to go in the future with these relapse refractory treatments. And what we're doing right now for early relapse versus, these new therapies are in late relapse, which is a problem. We can't get all our patients to these therapies because of access or because if their myeloma is high risk. We talk about risk. Thankfully, high risk myeloma is about 20-25% of patients. But if you have high risk disease, which is about 50% of my patients, it's really tough. We get through these therapies so fast that I really want to get them to these other therapies. So I think that in the next year, we're going to see all the data from the earlier lines of some of these immune therapies. And what I've gotten to see with some of my patients on those trials where we really changed outcomes for both standard risk and high risk, but to add years and years to my high risk patients is what really tells me that these new therapies are going to change everything by the time they're all retired, but I'll still be around. But hopefully, again, just curing everybody and then hanging out and giving talks everywhere, right? Of how we did it, how they help me, everybody else in the future do it. Okay, so relapsed refractory multiple myeloma. There we go. Okay. So my overview, really, I'll just talk about the implications of being relapsed refractory. What does that mean? We throw these words around all the time. And my patients usually like, what is that? And then the new and old targets. So I'll talk a little bit about translocations and deletions and what we're learning about the inside of that myeloma cell. What's driving that myeloma? And can we use therapies to specifically go after certain changes that patients have, certain FISH aberrations or cytogenetic changes? That would be an ideal thing to have biomarkers that tell me the day I see a myeloma patient, based on everything I know on their cytogenetics, their FISH, what's on the outside of the cell. So I know exactly which of these therapies to give them, but we're not there yet. And it's probably going to take a while. And so really, we're learning more and more. So I'll give you a little bit of that. And then overcoming clonal heterogeneity and evolution. So I'll talk a little bit about what are myeloma cells when we have MGUS or smoldering myeloma versus when you have active myeloma, and then what treatments can do, to change what your myeloma is doing over time. And then specifically, I'll talk about the bispecifics and ADCs, and Dr. Verdeja is actually going to talk about the CAR Ts today. So what is relapsed disease? So obviously, the cancers come back. And as you saw, we are curing about 15% of patients, which is great, but we want that to be 70, 80, 90%, right? So how do we improve that? But for most patients, it is going to come back probably multiple times. Our goal is to make that time farther and farther each time with these new therapies so that we have even other better therapies until we can finally cure more people. And in clinical, so there's people who clinically relapse, meaning that they have organ involvement that's causing symptoms. And again, these are the CRAB criteria we always talk about. So the calcium being high because there's bone disease or anemia or kidney function issues that happen. And really, we don't want to get to this. If we can find a way to treat patients before they get to this, that's what we want to do, because this is what causes symptoms, right? However, sometimes we can't actually catch it. It happens in between. Then there's progressive disease as a biochemical progression. So that's where I, really want to make sure I'm watching my patients very closely. And when I see these numbers go up, right, those proteins in the blood, the urine, on scans, even if we see something early, this is where I want to catch my patients so that I can treat them earlier to make sure they don't have those clinical side effects afterwards, which can then affect your ability to go on clinical trials, things like that. And then refractory disease, again, means that the cancer stopped responding to a treatment. So a lot of patients will potentially, stop treatment because they've done so well for a long time. And if it's been many years before you relapse, then we don't call that refractory. But if you're on a drug, let's say you're on, lenalidomide or daratumumab, and you're relapsing on that, for instance, during maintenance, that means you're refractory to that drug. And why that matters is when we look at these clinical trials, we talk about patients who are triple refractory versus pentarefractory. And it's really all those different lines of therapy. So we have our proteasome inhibitors, our immunomodulatory drugs, as Dr. Chari showed, our monoclonal antibodies. If those three drugs, the daratumumabs or the, bortezomibs or Velcades and the lenalidomides, if you've relapsed on all of those while being on it, we call that triple refractory. Then you add the other ones, so pomalidomide and carfilzomib. When you have all five of those, we call that pentarefractory. And what it tells us is that the myeloma is more aggressive now. And when we do clinical trials for relapsed refractory patients, when a drug first comes into the market, someone says, oh, I found something, and I want to try this in myeloma patients. It's usually in our really relapsed refractory patients that we started in. And once we know it's safe and it's working, then we start moving it up. And so that's what, in terms of clinical trials for our relapsed refractory patients, this is what it means. And then coming back to the goals. So really, we know, as Dr. Chari said, the response, when patients respond, when we see their numbers go down, the better response patients have, that complete remission or the MRD negativity, the minimal residual disease negativity, where we do a bone marrow, we can't find that myeloma, their PET scans are clean. We know that leads to better survival. So the myeloma stays down longer. And then it actually improves quality of life too, right? So our goal is always quality of life is just as important as that survival piece, because I want patients to have a good quality of life as they're living longer. And so that's, I think, coming back to that, decreasing the dose or stopping certain medications once it's working. And if it's causing side effects is so important to talk to your doctors about. Bring up the fact that, oh my gosh, I'm having this numbness tingling, I'm having some balance issues, because we don't want that as your quality of life. We can actually stop it and turn that around. And they all go together. So the other important piece, as I said, patients can have different types of myeloma. So myeloma is not the same. I joke to my fellows that multiple myeloma really is because there's multiple myelomas out there, that people have different types of disease. And so there's some patients in that green where we're just seeing that M protein go up a little bit, and it can go up and down over time, and it's not doing anything. It's sort of like an MGUS again. We just monitor it, right, until it gets to a certain level. And then I'll say, okay, maybe we need to start treatment. So my standard risk disease patients who have been doing really well for a long time, I just sort of watch. And then when we get to a level, we say, okay, let's look for clinical trials that might be appropriate, or let's do this next therapy before you have, active disease in your symptom, in your organs. Then there's high risk patients. So my high risk patients, I take those changes a little bit more seriously. If it gets that M protein gets to 0.5, or where, someone has, some pain, I quickly do MRIs, because high-risk patients usually relapse faster, and I want to catch it much faster. And then the red is really, again, where we don't want to get, but sometimes patients have symptomatic or extramedullary disease, especially our high-risk patients. So those are my patients I wish I could have treated, weeks ago or months ago. And it tells us how much time we have for clinical trials. So for anything that's out there that's really exciting, more green or yellow you're in, that is much easier for us to get to, those newer therapies faster. And then coming back to Dr. Chari's point, he probably recognizes some of these slides because there is, he's so great. Why reinvent the wheel, right? So really it's your risk and benefit. So patient related, so if someone already has neuropathy that's really bad from diabetes, I don't want to add to that. So I might change their therapy based on that. And then looking at disease related. So what is the rate of growth of that myeloma? Do I need to do something aggressive? Or, hey, it's just slowly waking up, that I can kind of, give something that's going to knock it right back down without causing major issues. And then treatment related is so important. So coming back to it again, I wish I could take a myeloma, test it, and know exactly which treatments to give when, but I can't. I don't have that. So what I do have is how patients actually reacted and how they responded to prior treatment. So if in first line, we saw that this patient just did really well with this drug, then I know that in the future, a drug in that same category is probably going to work a lot better for that patient. Now, some patients, everything works. So we have all these options. But for some folks, certain different types of drugs work better. So that piece is really, really important as well. Okay, so coming to the clonal heterogeneity. So that diagram on the left is sort of in the bone marrow. Initially those green cells are all normal B cells, the normal B cells and plasma cells we have that give us immunoglobulins that help us fight infections. And when patients get MGUS, all of a sudden there's one or two of those cells, those plasma cells, that got some kind of change. The fish studies that we look at, the cytogenetics, which is, I call it the DNA of the cells. It's like the hardware of the cells. Something happened where they're becoming the same cell again, and they're making a protein that doesn't do anything. It's not helping us fight infections. And that's where we see an M protein, we call it MGUS, because it's not causing problems. And then as patients turn into smoldering myeloma, so not everybody with MGUS gets myeloma, right? And so this is why we don't treat those patients, but about 1% chance per year for those patients to get smoldering disease. Smoldering means now we have more myeloma cells, maybe 20, 30%, and they're still not causing problems, but we know those patients are at higher risk of eventually getting myeloma. It could be many years. But as these steps go on, you get more and more of these myeloma clones with different plasma cells that are a little bit different from each other. And why that's so important is that, when we're treating, so that was until myeloma, but each time we treat, as Dr. Chari said, until I came along, basically that every time you treat, that time period of when that myeloma stays in remission or a response, it's hibernating, becomes shorter and shorter, because now we're getting more and my myeloma cells that are getting smarter and they're acting differently than each other. So one drug doesn't work. And why we talk about combination therapy is for this reason, so that we can kill all these different myeloma, clones with different drugs that can actually hopefully knock all of them down. So there's not one thing that I can give that will kill all those different clones, especially as patients become more relapsed refractory. Until the immunotherapy came. So I'll talk about that in a second. So again, Dr. Chari's lovely chart here, repetition works. So, so really, in terms of what do we use for first relapse or second relapse patients right now, what's approved are therapies that are combination like daratumumab, pomalidomide, immunomodulatory agent, and dexamethasone, right? That's a triplet that's approved in second, third line of treatment. Or daratumumab or isatuximab with carfilzomib and dexamethasone. So lots of different combination therapies with some of those older drugs that we've had. And then the newer immunotherapy, these are the ones I call real immunotherapy. And basically the CAR-Ts, the idacaptogene, the ciltacabtagene, and then of course teclistamab just got approved last week or a couple of weeks ago in the US, the bispecific. Those are approved in fifth line patients, right? So you have to have relapsed multiple times. If we can get clinical trials for earlier, I really try to get my patients on that. But really, until we have it approved earlier, that's for a later line therapy. So again, for most patients in second, third, and fourth line, I'm using all these other drugs and different combinations based on what what they actually did well with before, what kind of disease they have, how quickly do I need to get it down. So all those plus all the patient-related, comorbidities, et cetera, that we talked about. Okay, so then two ways that we're looking at relapsed or just myeloma in general. So in immunotherapy, instead of looking at the genetics of the cell to see how do I treat this, it's these things called antigens. So all of our cells have these flags that tell us what that cell is in our different cells in our body, and it helps us figure out how to get something to that cell to kill it. So the antigens are really important that you pick something that's only on myeloma and not on your normal cells, because otherwise you'll get really bad toxicity. So initially in lymphoma and leukemia, they found something called CD19. So they've had this for a long time. We tried it in myeloma. It doesn't work very well. So until we really figured out that BCMA or B cell maturation antigen, which is on myeloma cells, so 95% of patients have this, and it's usually on all the myeloma cells. So even though we talked about those different clones, all the different clones will still have this target on there, this flag. So now we have all these options of putting a T cell, the CAR T cell, right? You have this receptor that you put in there. It's night vision for those T cells. We grow them, then we give them back to you. So now they're like, soldiers going in directly killing that myeloma based on that flag that they're finding. And then the other, bispecifics. So I call those handcuffs or magnets. On one end, they can actually pull the T cell and they have a flag for the T cell on there, CD3. And then they have the BCMA or some of the other targets we'll talk about. And then they put them together and they activate the T cell so that the T cell can actually kill within your own body. So we're not taking them out and then making new the receptor in there, but still they'll take your own T cells and bring them together and kill. And then what was really, really exciting in the last couple of years is now we have new flags that we found on myeloma, which our lymphoma and leukemia colleagues don't necessarily have. So GPRC5D is another great target that's on myeloma cells. It is on some skin cells and other things, but nothing that's been known to be vital. So, like your heart or anything like that. But it's another flag on myeloma that we can use to get these bispecifics. There's CAR-Ts that are in early studies now that are looking at really good responses. And then on the FcRH5, another big target. Again, most patients with myeloma have this on their cells. So, these are all targets that are 90 to 100%. We see them on all myeloma patients. And so when I said earlier today that I'm really excited about combination therapy, this is really what excites me, that we talk about chemotherapy being combined together. And so what about immune therapy? So right now we don't do this, but really the future trials are going to hopefully look at the patients who don't, let's say, get that 4 or 5 years, from their CAR T right now. Can we combine these to kill all the different clones that myeloma has with different targets and different mechanisms of action? So bispecific and a CAR T, or other regular treatment like daratumumab and a bispecific. So there's studies with daratumumab and teclistamab, for instance, looking at pure immunotherapy, but combining them to see if we can kill all those myeloma cells once and for all. Okay, and then to kind of, I'm an immunotherapy person, so I talk about that all the time, but there's also lots of things that are going on in the targeted world. So coming back to multiple myeloma and the changes we see in those plasma cells, and again, no one has 100% of any of these in their myeloma, but most people have 1 or 2 of these. Some folks don't have any, but really these are all those different genes that can be changed in the myeloma that helped make it become myeloma, or just tells us it's a little bit more aggressive. So there's different high-risk features. I'm not going to go into all of that. But what's really, really exciting is that for patients who have 11-14, so chromosome 11 and chromosome 14 in the myeloma cell, something happened with them where they got translocated. This is not something people are born with. It's not, a genetic abnormality that puts you at higher risk of myeloma. We don't have that. But in the myeloma cell, when it becomes myeloma, we can find this in about 15 to 20% of patients. And what it does is that there is, at the bottom, I'm not going to go too much into it, but there's a protein inside the cells that it makes high, something called BCL2. BCL2 is something that tells your cells to keep growing, to keep expanding. Usually all our cells know when to die. When they've done their job, they shut off. BCL2 tells it, nope, just keep growing, keep growing, keep growing. And there's a drug called venetoclax that we use in leukemia that actually blocks BCL2. So for those patients, the 15-20% of patients that have this, venetoclax has been this amazing drug that it's a targeted drug. And this is with Velcade, bortezomib, but you can see the lighter purple line. Patients are doing, this was 36.8 months that most patients stayed in remission versus the placebo arm, which is the darker purple line, which is 9.3 months. So this is one of our first sort of treatments that we have for specific changes, genetic changes for myeloma. And hopefully, there's gonna be more and more as we're learning that we can have targeted therapies too. So really combining, immunotherapy and targeted therapies is sort of where we're hoping to go in the future. And so with that, I think a combination therapy. So in second and third, fourth relapse right now, really that combination therapy, because of those different clones, we want to knock it down. That's really the goal right now. And single agent really doesn't work. So I've had some patients getting just 1 or 2 drugs where they don't have a great response. And we know that doesn't work. We want the combination therapies. But once you have a great response, coming back to what Dr. Chari said, decreasing the doses so that we can make sure you don't have toxicity, right? That quality of life piece still has to be really, really with the other part of it. So, and what I'm really excited about is that these new antigens and these new targets we're finding are making us smarter so that we can target those myeloma cells better and hopefully decrease toxicity and really kill every last myeloma cell possible. And again, I think this afternoon you'll talk a lot more about the supportive therapy, but infections, especially with our CAR Ts and our bispecifics right now, most of my patients are getting, infections that we didn't necessarily see before. So if you're getting fevers or anything's happening, talk to your doctor so we can look for those. That supportive therapy piece is so important for our patients to survive and have good quality of life too. These are great therapies, but they don't come out, they do have toxicity that we have to manage and make sure nothing bad happens. So with that, I would like to thank all our patients and caregivers. Again, without all of our brave people here, all my patients that, take that chance to get a better life. I can't imagine having to make that decision, but because of that, you're helping so many other people, and hopefully we can finally cure this for more and more patients.